Good evening, everyone. Thank y'all for joining us tonight for our Addressing Disparities in Medicine panel. We're very excited to see so many of you here and excited to have gotten so many questions from our audience members. In case you're wondering who this person on the other side of your screen is, my name is Giselle Bello. I am a fourth-year medical student here at Brown, and I'm also the Diversity and Inclusion Fellow for the Office of Diversity and Multicultural Affairs. But we're really here to talk with the panelists. So on to our panelists. So can I have y'all introduce yourselves, who you are, what you do, and some background on what brings you here to this panel? I'm gonna start with Brian.
Hello, everyone. Thanks for having me here. I'm a third-year internal medicine and pediatrics resident at the University of Minnesota. I grew up in Rhode Island. I'm originally from Central Falls, and lived in Providence while I was in medical school. And I am interested in diversity, equity, and inclusion. It has been the focus of a lot of my work. And I look at the role of health inequities in health, and the role of physicians as well in mitigating health disparities. Since I've been in Minnesota, I've been getting involved a lot in healthcare activism, online and offline, and that has taken up a lot of my time. So very grateful to be here.
Thank you. Now I'm gonna have Maisha.
Hi, good evening, everyone. My name is Dr. Maisha Minter-Jordan. I'm an internist by training, also with a business background. I graduated from Brown undergrad in 1994 and the medical school in 1998. And since that time, really have been incredibly interested in how we can empower patients, particularly patients from underserved and underrepresented communities. After my time at Brown, I went on to Johns Hopkins to lead the medical consultation service in its first iteration when hospital medicine was just beginning. From there, I decided I really needed to understand how medicine is a business and how we can not only meet the importance of a mission, but also to create sustainability of that mission. And so I went back to business school at Johns Hopkins, and following that, my time at Johns Hopkins was really incredible in terms of doing more hospitalist medicine. But then I wanted to go back into the community. And so I moved to Boston, where I became the chief medical officer at a community health center called Dimmitt Community Health Center in Roxbury, Massachusetts, which serves primarily underrepresented communities, and then moved on from that role to the president CEO role, where I really focused on systems transformation and working with both the governor and the mayor on a number of committees that would help to uplift community health centers and the services that we provide, but also to represent minority communities at those tables, where often I was the only person of color at those tables making really important decisions about the healthcare system in Massachusetts and beyond. And from there, I moved to the DentaQuest Partnership for Oral Health Advancement, where I'm now the president and CEO, and I'm focused on oral health integration with primary care, primarily for underserved populations across the country. I'm really excited to be part of the conversation tonight and look forward to the discussion. Thank you.
Awesome, thank you so much. And last but certainly not least, Dr. Diaz.
Thank you, Giselle, and thank you for moderating, and thank you to all the participants. And before we get started, I also want to thank the Brown Medical Alumni Association and Kayla and Ellen for helping put this panel together. So I'm Joe Diaz. I'm the Associate Dean for Diversity and Multicultural Affairs here at Alpert Medical School. I graduated from Brown Medical School in 1996, and then stayed on to do a general internal medicine residency program, followed by a fellowship in general internal medicine, both at Rhode Island Hospital. I was then junior faculty up at Memorial Hospital, which many of you are probably familiar with, which unfortunately is no longer open. And from there, I was doing a combination of teaching, clinical work, and doing research, and mostly around cancer screening disparities. From there, I got my MPH again at Brown, and then eventually ended up in the Office of Diversity and Multicultural Affairs, which is where I am now. So, yeah, obviously diversity and equity are so tightly connected that this is really kind of all of our passions, and really thinking about diversity and thinking about inclusion and how the importance of a diverse workforce really impacts the equity and how we're caring for our patients. So happy to be here and happy you all can join us.
Definitely. And so the topic of addressing disparities in medicine is certainly a very multi-layered one. It's a huge topic. And so let's start with a little bit of a foundation. So can we speak about the role of racism in healthcare as one that actually causes health disparities? And I'm going to start with you, Dr. Diaz.
Yeah, sure. Thanks, Giselle. So obviously, I think that we need to, when we think about health disparities and we think about the role of racism in medicine, I think we need to think about the role of racism in general, right? So we talk a lot about the social determinants of health, right? And that's been sort of the new buzzword, the buzz phrase of the past few years. And I think that if we kind of rephrase that a little bit and talked about the systemic racism or the structural racism determinants of health, then I think we'd start to really think and get to the root causes of why we have such dramatic disparities in health among our communities. And then certainly when we look at medicine and we're a little bit of introspective in medicine, and we think about, I don't, certainly when I was in medical school, we didn't talk about this much, but medicine has a pretty significant history of racism in medicine. I think it's really important when we look about the structures that are in medicine, in medical education, in the structures of hospitals, we have to recognize and have to come to terms with our past and the structural racism past of medicine and the structures that are there. So I think without doing that, it's going to be really difficult to address racism, address disparities, and promote health equity. So I know that there are other panelists I'm certain have comments about this, so I'll turn it over to them.
Sure, and I'm happy to jump in on that question. I think, I completely agree with everything that you've said, and would also add that we as people bring some of the biases in everything that we do to work, and if you're a physician, if you're a nurse, if you're a medical assistant, a person at the front desk greeting a patient when they walk into the hospital, you're bringing that bias in with you. And I think part of what we have to do as we work towards dismantling the system is understanding that and understanding how do we get people to recognize that they bring that bias to work and recognize that that influences the way in which you interact with the patient, the way in which you prescribe treatment. You bring the bias of, as an example, Black people not experiencing pain in the same way that their white counterparts do. So understanding that and really helping to open up, again, looking at the systems pieces, but also looking at the human aspect of it and how the humans respond within those systems is also critically important. And that then leads to the outcomes that we see, the combination of the two.
I'll add also that I think when we think about health, the majority of our health is determined not by what we do inside the clinic, but really what patients do outside of the clinic. Where they live, what schools they go to, access to opportunities to stay healthy, access to opportunities to take care of the family. All those things that we know are related to health outcomes are patterned by race in the United States. When we look at risk factors in exposure to risk, like risk information, tobacco advertisement, all of that is patterned by race in this country. All of that, you see that where you live determines how healthy you are. And we know that people of color live in areas where there's concentrated poverty, where there's less access to health promoting resources, where there's more exposure to risk. And all of that, the reason why this is the way it is not by chance. There are policies and there are institutions that are upholding the system so that it produces the outcomes that it's getting. And a lot of those policies and institutions are rooted in white supremacy and are rooted in racism, are rooted in self-interest. And so, of course, racism affects health. Of course, it leads to health disparities. And there's also tons of research to suggest how. We know that it increases cortisol levels. We know that it causes stress. We know that racial trauma can cause a lot of psychological stress and harm There's tons of research to really prove this and to suggest this. So I think at this point, it shouldn't be a debate that racism causes health disparities and causes poor health outcomes. I think we really have to be thinking about why, and more importantly, what can we do to fix it?
Yeah, just to further your point, Brian, as you look at the life expectancy in Roxbury, Massachusetts, compared to that of a Black man, compared to a white man who lives in Back Bay, which is a much more affluent area of Boston, it's a 30-year difference in life expectancy. And that just follows on all of the points that you raised in terms of traffic congestion, air pollution, access to healthy foods, being in a food desert. All of those things are part of the system of racism that we're talking about. And I think your points are exactly right. And looking at the larger system and the policies and the regulations that allow for that type of discrepancy or that type of disparity, quite honestly, is what we need to do when we think about really dismantling the system.
Definitely. So thank y'all for your answers. So we heard that from Dean Diaz that definitely facing the history of medicine is one part of it. And we heard from Dr. Minter-Jordan that we're not really able to like split ourselves apart when we go to work based on like the lived experiences we've had and sort of the implicit biases that we all have. And then we also heard from Dr. Leva that the environment in which people live also have a great effect on their health outcomes. And so definitely a multi-layered problem, definitely a lot of approaches that can help solve the issue. But more specifically, I wanted to ask, what is the relationship between a diverse workforce and these healthcare disparities that we're talking about, and how do those two things go hand in hand? And I'm going to ask Dr. Minter-Jordan to start that, since you mentioned the idea of bringing our own internal biases.
Well, I think there's a case to be made for diversity of perspectives around any table where care is being delivered, or any table within a business, as I look at my own company, because there's a cultural competency that's involved in that. There's also an understanding of the culture or the people that you're impacting and working with that extends beyond just undergoing a training to understand and hear that. As a Black physician, very often I would have very authentic conversations with my patients around diabetes and around hypertension, and really looking and asking about these other pieces of their lives that would influence their healthcare. Let's talk about food, let's talk about housing. And there's a level of trust that is inherent in that type of relationship when you can culturally connect. It doesn't mean that every provider has to be a person of color, but when you have a diverse team, and we have this team-based approach that we've now moved towards in medicine, that team is better able to care for a patient when you have those diverse perspectives around the table. And it helps to mitigate some of what that implicit bias that others may bring in. Part of what I've also talked about much more recently is, as we talk about social determinants of health, as we talk about minority communities, we automatically shift in our minds to poor. But we know that many of the health outcomes that are experienced by people that look like me, Black women, there's no correlation between income. So when we look at maternal morbidity and mortality, it's irregardless of income. And so you need that perspective around the table to say, we're not making these assumptions about a person and say, well, they must be poor, or they must be this. It really helps to round out your assessment of the patient. It helps to round out the treatment plan and the expectations that you have for that treatment plan. But most importantly, it helps to build a connection with the patient so that they feel empowered in their healthcare as they're making decisions, and they feel a sense of trust with that team when they see that team is diverse and really focused on their healthcare.
Definitely, because patients also come with their own lived experiences and sort of their own past experiences with the medical field and just with other humans as well. And I just want to ask, does anyone else want to comment on that?
Yeah, I guess I'll focus a little bit on racial diversity. So we know that the medical workforce in this moment is largely white. Medical students in the US are largely predominantly white. And the truth of the matter is that our workforce does not reflect the patients we serve or the demographics of the United States. And so how has that turned out? So we've made great breakthroughs in diagnostics and therapeutics, but have we really moved the needle when it comes to racial health inequities? And I'll tell you that if you look at all the available data, even data that are examining trends in racial health inequities, all of that will suggest that we have not. If you zoom in on any racial group, let's just take a look at Blacks, for example, you'll find that they are more likely to suffer from certain health conditions. They're more likely to suffer complications from those health conditions. And in many cases, they're more likely to die from them, right? So stroke, 44% more likely to die from stroke. Asthma, 20% more likely to have asthma, 3 times more likely to die. Heart disease, 25% more likely to die. Breast cancer, 40% more likely to die. Prostate cancer, 2 times more likely to die. Cervical cancer, 50% more likely to have it, right? 72% more likely to have diabetes. 8 times more likely to be diagnosed with HIV, 9 times more likely to die. 3 times more likely to die from a complication from birth. I mean, if you really look from head to toe, you're gonna find disparities in every single racial and ethnic group that you find, right? And so, should I even keep going? I mean, if you even look at data among kids, you see the exact same thing. Me being MedPeds, I feel like this is something I should mention, right? 2 times more likely to die from sudden infant death syndrome, 2 times more likely to have asthma, 2.5 times more likely to die as infants, right? So it's clear that we really need to do something, and that they're really, these inequities are really undermining not only our ability to care for patients, but also our entire health system. So I'll ask you, how do we reduce health disparities, right? I think we need to work together to make healthcare more accessible, but that isn't gonna do the trick in and of itself. We also need to look upstream and work to address the structural determinants of health if we want to make any sort of dent in addressing health disparities. And so we know what the call to action is. The now question becomes is how are we going to do it? Mm-hmm. And that's where people come in, right? We know that URMs are more likely to work in underserved areas. Patients are more likely to be satisfied with care when they receive care from a doctor who matches their ethnic or cultural background. Moreover, URMs have been historically leading the way when it comes to research to address and mitigate health disparities, right? They make health disparities a priority. Health disparities must be on the agenda if we want to address it at all. If it's not on the agenda, it's not going to be addressed. And the truth of the matter is that Black, Indigenous, Latinx, and people of color put health disparities on the agenda. And I'll add that they bring a type of passion, a type of understanding, a certain skill set, connections, and then empathy really rooted in our lived experience that only they can offer. So I absolutely think that diversifying our workforce is going to be critical if we want to make any sort of dent in addressing health inequities.
I'm gonna go ahead and give you a snap all of those stats and for breaking that down like that, because as I was hearing you sort of just continue to give more and more examples, as like daunting as it was, that is the severity of the situation. And so thank you for doing that. Mm-hmm. I also just wanted to say quickly that as much as I also agree with the diversifying the team, I also think that interdisciplinary teams are like key to this as well. So not only in diversifying the lived experiences that your team can bring to be able to see your patient in a different light in different situations, but also having not only doctors be able to look at the patient, because we love medicine so much that sometimes we forget about the social aspects of things because we want to help cure the medical issue that the patient is having. Mm-hmm. So that's my piece on that.
Yeah, I just on that note, I wholeheartedly agree with that, Giselle. When I say team, I mean interdisciplinary team. We're talking about community health workers, we're talking about social workers. We know mental health is a huge issue within underrepresented populations. And the fact that they don't have someone who either speaks their language that they can actually address their mental health issues with is one of the barriers that people face. I also mean that in the context of what Brian, his points in terms of the data. Researchers, and when we're designing research protocols, what we find is that people of color are not part of that. Mm-hmm. There was a huge movement in terms of the development of the vaccine for COVID of engaging populations of color and trying to move past some of the barriers that people have historically experienced in terms of being part of trials. But when we're left out of those trials, then the answers that we come up with and the treatments that we come up with are often not as effective in populations of color. So I think when we talk about diversity around the table, we should be thinking about that in all forms, not specifically about physicians, but about interdisciplinary teams, research, business. It has to happen at every level if we're really trying to combat a system of racism.
Absolutely. Just because you mentioned the URMs that are near and dear to my heart as a URM myself, we had a question with regards to how do you convert intention into action when it comes to increasing the number of URM students and residents that are coming through the medical school system. As we mentioned, that was one of the things that we think is part of healing the system. So how do we convert that intention into action? And I'll start with Brian.
Thanks, Giselle. I mean, I think, you know, I just stated simply, we have to be intentional, right? So it's not just enough to want to do it and, you know, to wish it. You have to actually create action plans to make it happen. You know, and we need targets. We need actual measurable targets. What are our goals? When we say we want to increase the number of African-American medical students, by how much? And by when are we going to get there? And what are our targets? And then how are we going to incentivize our leadership and the people in positions of influence to make sure that that happens? You know, at the end of the day, you get what you incent, right? You need incentives and you need accountability. And so it's not just enough about creating targets. You also have to hold people accountable for not meeting those targets and incentivize them when they do. You know, and so I think that in order for us to really make a dent in increasing the amount of URMs in medicine, we have to create action agenda items, and we need plans, and it has to be within and throughout the organization. Every single office, department, and unit has to be part of this and has to believe in this and has to want to make this happen. You know, I always, when I think about, you know, diversifying, particularly in thinking about what institutions can do to increase diversity, I always say you have to start within your own house first, right? You have to look within and not just without, right? It's so easy to point the finger and say, well, you know, we are not getting enough applicants, or, you know, there's just a pipeline is too small and we got to work on the pipeline. No, there are tons of interested students who want to go into medical school and have exactly what it takes to get there and to do well if they're provided the resources. And so, you know, I would really urge, you know, institutions to stop looking at other reasons for why we don't have a diverse medical student workforce and really start looking inside. What are you doing to keep the medical students that you have? What are you doing to keep the residents that you already have and making sure that they're staying in your institution? You know, that's the lowest hanging fruit. And if and it's really important that we begin to address this. When we talk about inclusion, it's not just enough to have a diverse workforce, but you have to make sure that they feel welcomed and they feel that they can bring their whole selves to the job when they're there. And so part of that is asking them and listening. You know, this is becoming very popular, but when, you know, listen to Black people, listen to Latinos, listen to Latinx, when they tell you that what are the issues or why they don't want to, why they're looking at other institutions, take that into consideration and try to change it. You know, we know, I think that there's things that we could be doing to attain more Latinx and Black and Indigenous folks in medicine. I think we need to be looking at, like I said, our climates and making sure that we're addressing a culture of racism and microaggression. I think we need to be looking at our abilities for URMs to thrive, right? So if they are interested in a research career, are there actual funding mechanisms that incentivize, that provide resources and funding to that, for that kind of research?
Mm-hmm. Sorry, you're reminding me of Dr. Uche Blackstock's piece of why doctors like me are leaving faculty positions in academic medicine, that I'm sure many of us here have read, and just having to not only bring people in, but also the more important part is being able to sustain them while they're there. And so even just like the thought of microaggressions, how sometimes they really are just like macro ones, you know, that like we live through and we experience, and how that sort of ends up making us not feel completely comfortable in the spaces that we're in and that we actually are really passionate about inhabiting. I think you made an excellent point that is a great transition to ask Dean Diaz to sort of pitch in about. Just a point on that, it should be every every office in the medical education building should have this on their mind. It should not only, for example, here be the Office of Diversity and Multicultural Affairs that is really preoccupied with bringing and increasing the number of URM students, right? It should be like OME and OSA and like all of these things. And so I'm gonna transition that over to Dean Diaz and ask, what is Brown doing about this?
Yeah, so as Brian was making those comments, that's exactly what I was thinking, Giselle, is that it can't just be one office. It can't be just the diversity office. It really has to be a core value, right? It has to permeate everything that in all the offices. So I think at Brown, at the medical school, we're fortunate that the Office of Student Affairs, the Office of Medical Education in particular, I think with each year, it's becoming more and more of a stronger value. So when, and students, and as Brian is referring to, when students have ideas or suggestions about the curriculum, for example, I think the Office of Medical Education here really listens, and they want to hear what the students have to say, and then they take that and look introspectively within the office and say, okay, how do we change this? How do we make this better? So I think each year it's hard for the current students to see, because so Brian, if you came back now and looked at the curriculum, you'd probably say, oh, look, this has changed in a good way. So I think that's one thing that's really been really nice about Brown, is that they really take it as a core value, and that value has been growing over the past few years. I think it's really been growing, and it's certainly not in small part. It's actually a large part because of the students, and the students that then become alumni and provide that feedback, and the faculty, and really I'll tell you what, the students that become alumni and then come back to become faculty are really some of that's like the trifecta. So there's some really great examples of that happening. But I really think it has to be a core value of the institution and of the institutions that the medical schools work.
Yeah, just my quick add to that. I remember dinners with Dr. Levi Adams when I was in medical school, and that type of and he was just so incredible to the students of color, and wrapping his arms around us and making us feel like we were home. And I will never forget that. And I think that was an incredible moments that I shared with other students during my medical school training that made me feel like I belonged. But I think your point, Brian, around not only recruitment, and your point, Giselle, as well, around how do you retain people, right? What does retention look like? Retention doesn't mean you've gotten here and now go. It also means what are the images on the wall that I see? What does the board of directors look like? What does the faculty look like? Are there opportunities for me to advance in my career? And are we connecting the students with those faculty in a way that is authentic, like was done with Levi Adams, which I think he did out of his heart, and wanting to make sure that we, as Black students, Black and Brown students, felt as if we belonged. But I think doing that with intentionality, and to your point, setting the right measures, But I think the measures are one piece. It's really like, where are we going? What type of relationships are we cultivating with, you know, with other schools in terms of recruitment? Are we going to the HBCUs? Like, there's intentional stuff that can be done. And to your point, moving past the idea that these students aren't ready for the rigor of Brown, they are. We just have to make sure that we make those intentional connections.
I can certainly say for myself that entering medical school, especially at Brown, I didn't necessarily feel like I was ready for the rigor. Thankfully, I definitely was. And most of that was for that exact thing that you mentioned, the support, the being able to feel like something also that Dr. Leva mentioned, just being able to be my whole self. At the medical school, it was something that I saw other students were commenting on. Brian was certainly one of those students that was sort of telling me a little bit about what being a Brown student was like. And I definitely wasn't fooled because that has been my experience. And so being that we all went here, my question now is, how does a medical education from Brown prepare physicians to address issues as significant as disparities in healthcare? And I'm going to start with Brian.
Thanks, Giselle. I am forever grateful for the education that I received at Brown. I think because Brown really produces critical thinkers. And I think that at the end of the day, if we are going to solve health disparities, we need to be able to think critically about the issues. And that means getting education around them. So at Brown, for example, there was a healthcare elective called Healthcare for the Underserved, which I took. There were opportunities to get involved in the community. I was involved with both the SNMA and the LMSA, which helped to create or cultivate my consciousness around racial equity. There were faculty whom I could go to talk and do research, for example, Dr. Diaz. I felt that the medical education office was receptive. Dr. George, for example, is just an incredible person and really is there for students and really looks out for your best interests. And so I do feel that Brown has the infrastructure and has been a leader already in these issues. I mean, I'll tell you, moving to the University of Minnesota, where I'm at now, I think that Brown was ahead of the curve, right? I think I'm seeing my institution really wrestle with issues that we wrestled with when I was a student at Brown, right? Creating task forces that we already had created when I was a student at Brown. And so I think Brown, there's no reason why Brown can't be a leader in this area. I fully expect it to be a leader in this area because they've been already doing a lot of really important work. I think some of the things that make Brown unique are our scholarly elective program. I think Brown, that really sets it apart and allows students to really take their education into their own hands. But I also think that in order to really, I think, move the needle, we really do have to incorporate this kind of curricula into mainstream. And I already saw Brown doing that when I was a student. So it doesn't surprise me when I hear you, Dr. Diaz, say that the curriculum has been completely revamped. I think that's the kind of energy that we need if we want to create doctors that are going to be able to take care of patients in the 21st century.
Definitely.
I would underscore everything I think that you just said, Brian. I mean, for me as an undergrad and as a medical student, Brown was the place where I was allowed to grow, allowed to be curious, intellectually curious. Where in my training as a physician, I had the space as a medical student to be the one to go back into the room to a patient of color and say, did you understand that? How can I be helpful to you? And it was the expectation that as a medical student, that that's what you would do. And so I think it was an invaluable time in my life that opened me up to the possibilities within medicine that prepared me to be a really, what I consider to be a good doctor, meaning that, and what I consider to be a good doctor is one who deeply cares and is empathetic with your patients in their journey, in their experience. And even in the training of how you did a history and physical, those questions were important. Before social determinants came on the scene, we were asking about those things, about food and about housing. And so for me, that was the baseline, the structure that I had in terms of my medical career that allowed me to be where I am today. And so I'm incredibly grateful. And as Dr. Diaz was hitting me up to be one of the speakers at an upcoming dinner with the students, before he finished the question, I was like, yeah, I'm in, because that matters. And I think us coming back and giving back matters. And I think we do that because we understand the importance of the education that Brown extended to all of us.
I'm going to have you answer that question too, Dr. Diaz, because
yeah. So I agree with Maisha. I think that, obviously the curriculum has changed a lot since we were in medical school. But the foundational pieces that Maisha's talking about, I think we're there. We're there, a few years ago when we were in medical school. And in addition to that, I think it's the commitment of Brown and the faculty of Brown to help students really pursue their interests, and particularly interests with regarding social justice. So, with an undergraduate campus that you can, there's experts on the undergraduate campus. You can get involved there, and then you can get mentored by faculty and others who are doing this work locally and eager to mentor people. And so I think it's been, when I interview medical students and they ask me what I like the most about Brown, I say it's the people, and it's not just the people, it's the mentors and the mentors that you find, or that find you, frankly. Many of the mentors that I had as a medical student, as a resident, and as a fellow are now, I guess, my colleagues, but I still consider them my mentors. And because they really want to see you grow and pursue your interests, and because there's a rich tradition of social justice here at Brown, I think that certainly helps.
I agree with all of that, everything that y'all said, and being that I still do go here, I think that one of the really wonderful things as well, Dr. Minter-Jordan, you defined like what you think is a really good doctor, which deeply cares and is empathetic with patients. And in talking to some of my friends that have already become residents, apparently there's like a running joke in a few other residencies that when residents are that way, it's like, oh, you must have gone to Brown. That as much as like that's funny, it's also, I think, emblematic of the kind of people that we have here. That we already sort of come into this game wanting to be, deeply caring for our patients and being really empathetic. And that's certainly something that also drew me not only to Brown, but to medicine in general. To your point, Dr. Leva, about like critical thinkers, and then also Dr. Diaz about just the curriculum changing all the time. I think that one of the things that has been really sort of a pivotal change in my education here is that suddenly I felt like I was in a place in which like I was encouraged and like empowered to speak up, which is then why these curricular changes happen, why you can get involved in organizations such as White Coats for Black Lives, and why all of our students are like, oh yeah, I started this organization, or oh yeah, I did this. Like Dr. Leva over here with Woke Doctors. Is that what it is? Woke Doctors? Did I get that right? So, okay, we're not going to ignore the fact that the reason why we're having this conversation over Zoom is because we are currently still in a pandemic. And so a lot of the things that we've been talking about with regards to disparities have also played out with COVID-19 in our underserved communities, and specifically with Black communities. And so one of the questions that we got was, how do you propose we can improve education about medical conditions to improve compliance and follow up with patients? And if you want to give the spin specifically with like COVID-19. And I'm going to start with Dr. Minter-Jordan.
Sure. So I'm on the mayor's task force here for the Mayor's Task Force on Health Inequities from COVID-19. And part of what we were charged with when the pandemic hit Boston and when we began to see the stark disparities and inequities in terms of access to treatment was to begin to look at the data and really understanding at a neighborhood level and at the level of the different residences, what the statistics were to then allocate resources. So, and then it began, and then the most important piece, I would say, the constellation of people around the table with the mayor were people from the community, people from the medical community, local leadership, people from the housing authority. And it was that diversity that I talked about earlier in terms of perspectives around the table that then helped us to create with the community, what were the educational pieces that we needed to bring out? How would we bring that out? What were the numbers of the languages that we would put the information into? How could we create kits, and how did we start to dispel some of the rumors about COVID-19? And so I think when we talk about getting patients to comply, we also have to think about the language, right? Because when we say patients are compliant, what does that really mean? And when we say patients need to be educated, what do we mean by that? And so it's part of what we learned and continue to learn is that task force is how to meet people where they are, how to engage them in the problem solving, and to move away from the assumptions that we brought to the table. And so what we were able to very quickly do was to reduce the numbers, which albeit now are increasing again as this pandemic continues in its second phase or renewed phase, however we like to classify it. But I think the important lessons that we all learned from that was that we really needed to do that in partnership with patients. And I always feel that way when I was seeing patients and creating a plan of care. It needs to be in partnership. Like, let's do this together. Let's understand what are the barriers for you together and how do we create solutions to overcome them. So I think first and foremost, let's look at that language that we sometimes come to the table with. Let's move away from the hierarchy that sometimes is in our mind when we think about a physician and a patient, and really think about how do we do things together that then would produce the types of outcomes that are important for the patient first and foremost. And understanding what is important, I think, is key in that.
Definitely, thank you. Dr. Liebes, did you have anything you wanted to say about that specifically?
I think there's been so much, there's already been so much wonderful things that have been said. The only thing I would add is that COVID created new disparities. We now have disparities in COVID diagnostics, hospitalizations, deaths, but it also revealed disparities that we already knew were there.
Yeah.
And so the reason, I'm not going to absolve elected officials from the responsibility for why the pandemic is the way it is. I think when I think about activism, when I think about being a citizen physician, when I think about engaging in policy and in advocacy with my legislators, I think about it as a form of preventive medicine, because they determine how things like the COVID pandemic play out. Right? They determine where PPE is allocated. They determine who has access to ventilators. They determine when and where those things happen. So I do think that that a lot of what we saw with COVID in some ways was created again by policies and politicians in power, but in other ways was expected, right? Who are the essential workers? Who are those most at risk? Right? Who are more likely to live in multi-generational families? Who are more likely to live in crowded conditions? Who are less likely to have access to healthcare? Who is more likely to have fear of retaliation from an employer if they do have symptoms? All those things that we knew existed, right? The data has existed, this has been existing since I was in college and way before that, actually. barriers that affect other health outcomes are also at play here in COVID.
Mm-hmm. Definitely. And Dr. Diaz, I saw you shaking your head in
Yeah,
agreement.
I absolutely agree. And, you know, particularly with regards to COVID, there was an article, and I can't remember which journal it was. It was one of the public health journals. And if you just read the abstract, it was from H1N1. And if you read the abstract and just removed H1N1 and put COVID, it's the same abstract.
Mhm.
And that was how long ago? And so we've known that these disparities exist and that this is going to happen. And then going back to what Manisha said, and thinking about not just COVID, but health equity in general, it has to come in partnership with the community and what the community needs. I spoke with a local healthcare leader recently who had some ideas and thoughts about health equity, and then wanted to pull together this medical expert and that medical expert and this medical expert. And I was like, wait a second, no, I think what you need to do first is talk to the community and identify what the community needs and what the community priorities are, and then go back and involve the medical experts. But you got to start with the community. And if we're gonna address health equity, I think we obviously need to involve the community.
Absolutely. And I think that goes back to our prior point of being that caring doctor and empathetic with our patients. If we don't first understand their experiences with the healthcare field, how can we ever think that we can dream up ideas to be able to help them without a proper understanding? With regards to addressing barriers together and working in partnership with the community, can a provider open a line of discussion about how issues of structural inequity are influencing their decision-making about their own health? And if so, do you have any strategies for communication with patients in that way? And I'm gonna have anyone who wants to answer that question get started. Or I can pick on you.
I guess I'll start.
Okay.
Something that I'm doing right now in the midst of COVID, in the midst of racial unrest, in the midst of the economic crisis, is I'm asking patients when they come in what we all ask: how are you doing? Most patients will say, I'm okay. Especially when that relationship, that continuity may not be there, if they're a new patient. Typically what I say after that is, wow, I am so surprised that you are doing okay in the midst of everything that's going on. That really says a lot about your strength and your resilience. Tell me how you do it. And interestingly, I do find that when I say that, people are more likely to open up about how they're actually doing. So I think that's a simple tool that you could use currently right now, you know, to get people to really open up about how this pandemic, how systemic racism, how structural inequality is really affecting them. I think also asking them directly, and then making sure that you're telling them why you're asking them. You know, so in the case of, for example, racism, you know, you can simply say, you know, I've read and I've talked to people who've told me that they're experiencing racism in healthcare. Have you ever experienced racism in healthcare? I'm asking simply because I care about these issues, and I want to make sure that we here in this clinic are doing everything we can to make sure that you feel that you belong here and that we're not perpetuating racism. So in not only asking them, but also telling them why you're asking them, I think that can go a long way in having patients be willing to divulge the information. Because they're also doing something about it if you do find out, right? Like if you find out that maybe there are practices in your own clinic that contribute to patients not feeling comfortable, contribute to patients not wanting to come in, making sure that you're following up and addressing them is critical.
Definitely, because I feel like that makes it so that we can break down that barrier between like the doctor and the patient. When you sort of are telling them not only why you're asking this question, but just showing general interest, I think is something that goes a long way in that trust building and that sort of dismantling the hierarchy. Anyone else want to chime in on this question?
Yeah, I think the other way in which when I was seeing patients, which I would address it, not necessarily to call it structural racism, because I think I wanted to make sure that patients understood what I was saying, and what I meant was to just kind of call out that experience, right? So I talked to patients about you need to stop smoking, and why what's the importance of in terms of you stopping smoking. Well, you're in a household that has children in it. You're in an area that is polluted. If you're really trying to save money in order to get your own apartment or to get your own place, that $10 or $20 a week that you're spending, we could use towards something else, just to try to get my patients that I work with to understand that there's a bigger system that they can impact by their choices. And so that was a lot of the conversation that I had. I think also giving them the tools if you're going to the hospital, if you're meeting with the surgeon, you want to be prepared with your list of questions, because you're not going to have a lot of time to get those questions in. And if you feel like those questions weren't answered in a way that was respectful to you, I need you to let me know that. So really trying to problem solve about what I knew their experience might be. Or if you get to the hospital and there aren't interpreters present to help you, I need you to let me know that, so that I can call the hospital and talk to them about making sure that they have interpreters present to help you in your care. Like, you should not go there and experience this. And so for me, it was really talking about the possibilities of what they might experience given the system. And I think I love, Brian, the way that you're approaching things, and now in terms of calling it out. But I think when I was seeing patients, it was really more so like, let's talk about these experiences and let's make sure that you understand that that's not how it's supposed to be, and that I'm your advocate, and really trying to call out the specific experiences and asking them whether or not they experienced that when they came back from seeing a specialist or had an interaction within the larger hospital system. So for me, that was really important. And so I think, there are different approaches that one would take, but calling it out for what it is, but also naming those experiences so that you can, sometimes people, you talked about microaggressions earlier, they don't see it or they don't recognize that that is part of this system of racism that we experience often as patients, and really giving them the tools to be able to navigate that, and to let them know that I would help in terms of being their advocate so they didn't have to experience that.
Definitely. So we're coming up on almost an hour, so I'm going to ask one last question. What opportunities do y'all think will emerge out of the current crisis and eventual recovery for transforming healthcare? So now a lot of the visits that are being held are virtual health. And so that's one part of the question. And then what steps can be taken to assure that these innovations benefit lower income populations that might not necessarily be online? And I'm going to ask that to Dr. Minter-Jordan.
Sure. So I think the first thing I would challenge is the idea that people may not be online. I think part of what I found in my community health center work was that most patients have smartphones, and most patients have a way to access. It may not always be the same phone number, it may be a different phone or a different carrier, but I think we make assumptions when we think about innovation and the ability to bring innovation to underserved populations by saying, well, they just won't have access. Clearly, we've seen, particularly with internet, et cetera, with kids learning, this is a different issue, but I think, and related issue, but I think at the same time, we should challenge ourselves in that notion. I think the idea now and the uncovering of the inequities and healthcare inequities and the heightened focus on them, particularly within COVID, has allowed us to really leverage data and leverage systems working together to really combat COVID. For the first time in probably forever, the hospital systems in Massachusetts share data. How many ICU beds do you have? How many ICU beds do you have? And the idea that that can happen, and now the framework is there for that to happen into the future, is a way in which we can start to allocate resources. So I think using data to allocate resources, using innovation like telemedicine, teledentistry in the context of the work that I do to provide access and to focus on prevention. I think particularly within oral health, we often move to, well, we have to do something. Our oral health providers are doing procedures, but also there's a lot of room for prevention, and we leverage telemedicine, teledentistry to do that. particularly for underserved populations, can really move the needle on healthcare inequities. Some of the providers that I've spoken with that have leveraged teledentistry and telemedicine note that there's a better connection between their patients because it's this one-on-one time, and it actually can help promote the patient-physician relationship in many instances. Clearly, nothing takes place of being in person, but we can leverage this technology to provide more prevention to underserved populations and greater access in many instances as well, particularly within rural or underserved communities. So I think there's a ton of possibilities with where we are now, leveraging data, leveraging technology, and empowering patients in their care.
Thank you. Anyone else want to chime in on that one?
I'll just add real quickly. I agree that I think that we often forget about smartphones and the penetrance of smartphones, and that's really a way for many people to access telehealth. There are, at least anecdotally, one of the things that we've found is that particularly for our older patients, patients that are living in senior high rises, for example, have had significant difficulty connecting with telehealth, particularly when early in the pandemic, everything was basically virtual. So, but we're also taking that as an opportunity to try to figure out, okay, novel ways to do it. So actually, we're about to start a pilot, which we're calling facilitated telemedicine, where we're going to have a community health worker who's going to go to the senior high rises locally and provide that sort of, just that next step, that connection to the doc. Not much more than being able to provide a laptop or a tablet computer and then connecting into the doctor's office. So the patient doesn't have to worry about, one, leaving their building, and two, having to jump over the barrier, sometimes the barrier of the connection and the technology.
Do you have anything to say to that?
Yeah, I think COVID has been an interesting experiment, and it's just I think a natural experiment in our ability to get things done when there's political willpower. Mm-hmm. Let every activist, student activist, or physician activist out there use this experience to push back when someone says, we can't do it, the system isn't set up for it, we don't have the time or the resources, it hasn't been done before. COVID showed us that when there's will, we really can radically change the way we practice medicine in ways that I never thought were possible. I work at 7 different hospitals in the Twin Cities, and all of them witnessed drastic transformations in the way they take in patients, in the way they do admissions, in the way they discharge. And so all of that was just dramatically transformed. Let that be an example for what we can do with addressing health inequities, increasing representation in medicine. If there's a will, there's certainly a way. I think also when it comes to how COVID is going to affect inequities and how existing health disparities moving forward, I really think it all comes down to whether or not we have these populations in mind as we are thinking about expansion, dissemination, upscaling, these telehealth technologies, right? So I think the idea, I agree with the other folks who were saying that people have access to technology, particularly, and that's not everyone, right? But particularly when we talk about rural health disparities, which I think telemedicine has an opportunity to address. At the same time, it can also exacerbate those disparities if those populations don't have access to the technologies needed to make telemedicine possible. Mm-hmm. But let's just assume that we're talking about a city or a town where everyone has access to a smartphone and has the technology to actually engage in telemedicine. I think if we don't keep those populations in mind as we make telemedicine or mainstream, I think we have there's potential to exacerbate existing health disparities. For example, I think what I'm seeing even in clinic now is it's amazing that patients can remain at work and still come to their appointment, right? Because I can just call them. It isn't amazing when the interpreter is just not there. And so then literally then that patient, we just can't have that visit. And so I think that, making sure that as we're implementing telemedicine, we're keeping the margins in the front of our minds, not in the back of our minds, but in the front of our minds, I think is going to go a long way.
Awesome, thank you. So that was the last question that I had prepared, but we did get one question that will be the last question because I want to be respectful of people's time. So the question was, in order to address the glaring disparities in care and outcomes, don't you first need to reform medical education and medical practice, neither of which are particularly scalable? It seems that already there is not enough care to address the needs of those who have access to it. Shouldn't you focus on training the care side and leave the rest up to the computers and systemized models of delivery? I don't know who wants to take a stab at that, but.
Well, just really quickly, because I know we're up on time. I mean, I think I would challenge the notion that reforming medical education is not scalable. I mean, I think I would want to understand how the person who posed the question is viewing a scalability. When we think about the reform that's already happened, as we heard earlier within the curriculum at Brown University, there's a movement to reform medical education across the country, given this larger recognition of the role that health disparities has in terms of impacting our communities. So I don't know that I agree with the notion that it's not scalable. The concern I do have about without doing that work and then fully depending on systems, computer systems, is that we can build the same systemic racism into computer systems that we are currently experiencing today. As we think about artificial intelligence and the programmers, without having diversity in addressing systemic racism in all of those settings where those things are being developed, we will perpetuate what we have right now. So I think both things, we need to address training, and that has to be done, and it is being done. And I think Brown is leading the way in that in curriculum. And we also have to address systemic racism on a larger level so that as we move towards more innovation and move towards greater use of technology, that we're not infusing it with the very tenets of systemic racism that we're experiencing now.
Definitely. And I think that same thing is what is applied to research, because computers and research programs give you the information that you ask it to give you. And so that was a great point that made me think of that. All right. Well, with that, I'm going to wrap it up. Thank you so much for your time, for the pearls of wisdom that y'all shared with all of us tonight, and most importantly, for all of the work that y'all do to keep battling and addressing disparities in medicine. I know I'm grateful to y'all as people that are ahead in their careers and that I look up to, and that certainly I'm sure people who tuned in today have so many things to look up to y'all about. So thank you so much for your time.